Basically, because of the impact that anti-amyloid therapy, so-called disease-modifying therapies, is about to make in clinical practice, I thought this would be an important lecture for you to go home with, and it's relevant to both neuroradiologists as well as any radiologists, particularly radiologists who are responsible for gearing up to answer the demands that are coming from the community. I think there will be material here that is really worthwhile. So let's look at this. Look at these opportunities and obligations that come from these amyloid therapies. And this article that my colleague Dr. Bash and I wrote on the same topic in applied radiology. Dr. Bash is really quite an expert in this particular area. She taught me everything she knows. All right, 7 million Americans suffer from Alzheimer's disease. Roughly 25% of those patients are in the early stages and are eligible for these amyloid targeting therapies, or roughly 15 million patients in the US. The prevalence of Alzheimer's disease doubles every 5 years after the age of 60, and 1 in 3 of our seniors will die of dementia. This is a major population health issue. While death from heart disease is actually going down, death from Alzheimer's disease with our aging population has increased by 145%. This posed about a $355 billion cost in the U.S. in 2021, and it's expected to climb to $1.1 trillion by 2050. There are 2 different types of Alzheimer's disease. There's a familial early onset form, which is only about 5%, but the late onset form is what we're here to talk about today, the sporadic form, and that's 95%. And the primary risk factors for this are age. It's more common in females than males, and there is a strong genetic predilection. And it centers around this apolipoprotein, ApoE4. ApoE4, that allele, is the primary genetic risk factor for Alzheimer's disease, and it is thought to lead to impaired clearance of these amyloid beta plaques. There are actually 3 different alleles, 2, 3, and 4. E3 is the most common and seen in 50% of the population, but 25% of the population carries one ApoE4 allele, heterozygous, and that increases their risk for Alzheimer's disease 3-fold, and a 2 to 3% of the population carries 2, which increases their risk of Alzheimer's disease 12-fold. Actually, ApoE2 is a rare allele, and that actually is protective against Alzheimer's disease. ApoE4 is a risk factor in Alzheimer's disease, but also cerebral amyloid angiopathy, which is very much a similar disease where amyloid gets into the vessel walls and leads to a lot of bleeds. You can see that's a very common fundamental pathophysiology with Alzheimer's disease. It is actually associated with a higher risk of the complications associated with amyloid therapy, anti-amyloid therapy, which is ARIA, but it's also seen in the dementia of Lewy bodies, tauopathies, and a few other circumstances, including traumatic brain injury. There are modifiable risk factors, and if I think about my behavior this week, I've probably doubled my predilection of Alzheimer's disease: smoking, alcohol, obesity and poor diet, lack of exercise and poor sleep, depression, low cognitive engagement and social isolation, as well as hypertension, diabetes, and again, traumatic brain injury. The fundamental pathophysiology of Alzheimer's disease is thought to be related to extracellular amyloid beta plaques and intracellular tau. Fundamentally, we're always producing, amyloid beta, but in this case, we have an imbalance between the production of this toxic protein breakdown product and the clearance. So you end up with accumulation of these plaques in the brain. These plaques, amyloid beta plaques, trigger critical pathophysiologic events, including aggregation of tau tangles, synaptic dysfunction, brain inflammation, and downstream neurodegeneration and cognitive decline. So it's thought to be the fundamental start is these amyloid plaques and what happens afterwards. What is tau? Tau is an intraneuronal protein inclusion resulting from misfolded and abnormally phosphorylated tau protein aggregation. We see this in the entorhinal cortex, as you can see here, and the temporal lobes. I'm going to give you my pointer right there. This is a typical positive tau PET. It is the lowest concentration in the sensory motor regions. Now, when it comes to PET, which is a very important part of this process in terms of entry into these treatment pathways, as well as making the diagnosis and establishing the presence of Alzheimer's disease, if you look at normal metabolic imaging, this is FDG PET, this is tau PET, this is amyloid PET, in FDG, which just marks brain metabolism, you can see there is symmetrical right-left, front-back metabolism. That's a normal-looking PET. A normal tau PET, you really don't see any tau accumulation. And a normal amyloid PET, you see what looks like you're marking the white matter. You're sparing the cortex. You know, there's a lot of ways, getting into the nitty-gritty and how to interpret tau PET. Amyloid PET is a bit more complicated, but that's what it comes down to. That's a clear positive case where the cortex is spared. Let's contrast that to this case, which is a clear positive case. That was a negative case. This is a positive case where you no longer see the gray-white differentiation. You no longer see just the central white matter mark, but you go all the way out to the cortical edge. Here in this tau PET, you can see there's abnormal tau clearly in the temporal lobes, and in this metabolic PET, this FDG PET, you see the classic posterior temporoparietal hypometabolism compared to other areas in the brain. Here's a clinical case from the literature. There's a little bit of a mismatch between the brain CT and the PET here, but you'll notice that the actual amyloid goes right out to the surface of the cortex. This is a clearly positive amyloid PET. And by the way, when you read amyloid PETs, it's either positive or negative. There's no in-between, which is kind of interesting. And they put you through a heck of a lot of training before you're certified to read. And this is an abnormal tau PET. You see it in the temporal lobes, but you also see it in the posterior cingulate region, which is really interesting. As a classic hallmark, but also with respect to a case that I'll show you coming up soon. Now, why are we excited about this for the first time? Because we now have therapies, and these therapies are monoclonal antibodies that target the amyloid, but also mobilize it. And the theory is there's too much production or too little clearance, but it's stuck in the brain, right? And these antibodies, they grab it, they essentially dislodge it, and then allow the normal brain clearance pathway to get it out. And what is the normal brain clearance pathway? What's thought to be this glymphatic system, where there's a bulk CSF flow from the periarterial space through the extracellular space to the perivenous space and out into the body's lymphatic system. Now, if you see these little brown bodies here, these are supposed to indicate amyloid plaque, but it could be any toxin that occurs within the brain, and it just washes through every day. And this happens more actively when you sleep, which is why sleeping is really, bad sleep is one of the big risk factors for clearing this disease. And we talked about this earlier with contrast agents where they stick in the brain, and the same process just washes them out. The first drug to achieve full approval is a drug called lecanemab. It's pronounced Leqembi. The actual clinical product was approved in July of 2023. In the trials on this agent, patients with mild cognitive impairment and mild Alzheimer's dementia showed a 27% slower rate of cognitive decline. You can see it here. This is cognitive. This is over time. This is a cognitive testing. You'll notice the slope of the patients on placebo, and you see the slope is different for the patients on lecanemab. If on an extension of this trial, if you looked at the patients with the earliest stage disease, when they have the least amount of tau, and this would be a low tau, and this would be a normal, and this would be a high tau example from Eisai, 76% of the patients who had low tau compared to placebo, 55% had no cognitive decline, and that's really big. And 60% of that same patient group had clinical improvement at 18 months, and they only saw that in 28% of the placebo population. So in general, the theme that starting earlier is important from you're eligible only in the early stages, and the earliest stages you'll have the best results are very, very important. Now, there's an imaging outcome that you can measure here, and this also impacts on whether or not PETs will be done to monitor the patient's progress. And it's shown that on PET, you can clearly demonstrate the difference between when you're on the drug and how many centiloids you can pick up of amyloid. With lecanemab, it clearly drops over time. With placebo, it pretty much it's a slightly ascending curve, as you would expect. This is an example of one patient on lecanemab. You can see the amyloid PET going right out to the surface of the brain, and after treatment, we only see that central marking, which is characteristic of a normal scan. Okay, I see. I think I have a typo on this particular slide. So right now, this drug is given in infusion centers every 2 weeks, okay? It will eventually get to the point where there is a subcutaneous formulation. And the subcutaneous formulation can be given just like the diabetes/fat control drugs are being given now, like Ozempic. So patient could self-administer, and this could go a long way to making this much more patient-friendly. Interesting enough, even though the subcutaneous formulation is more effective, it's not at any higher risk. Now, how big is this market, to the financial folks? Well, Eisai expects the drug, which costs $26,500 per year to the patient, to the system is covered by Medicare to bring in about $66 million during 2023. Right now, there's about 800 patients on the drug, but by the end of March, they predict that 10,000 patients will be on this drug. The next drug comes from Eli Lilly, and it's called donanemab. It's not yet approved, but it will be next in the pathway. I can tell you right now there are many, many drugs in the pathway, and many of them show even better results in terms of impact. So, this is here to stay. In this particular drug, during the trials, there was a 35% slowing of cognitive decline. And again, the earliest stages, the patients with the mildest disease showed the greatest effect. Here's an example of a patient in the donanemab trial, the placebo patient. You see that same marking right out to the cortex. The PET people call this kissing cortex because there's no sparing in between. And as opposed to a treated patient where you can see the impact has changed quite a bit. Now, what is the role of PET for us in radiology? Well, you can't get on this drug unless there is confirmation of amyloid burden. And this is traditionally done with an amyloid PET. Here, you see an example of a normal and an abnormal amyloid PET. You can do this by lumbar puncture, but at least we folks in radiology believe that patients will prefer to lay on the table for a PET scan rather than get a lumbar puncture. But both of them are accepted ways to go. What about reimbursement? Because there's been this issue over time that you can't get your PETs reimbursed in the brain. And even if you could, under special circumstances, you were only allowed to have one in a lifetime. Now, that national non-coverage decision has been rescinded now with the availability of these drugs. And they don't expect any national decision, approval or not, to become forthcoming. But CMS has stated clearly that based on the evidence, there will almost certainly be coverage from the individual Medicare administrative contractors across the country. So you can expect PET to be approved. I can tell you that over the last 6 weeks, we've done 46 brain PETs in Southern California just for this purpose. And again, you saw how the numbers are going to go up. Now, you think about the traditional role of MRI in Alzheimer's disease. We're there to exclude treatable causes, right? Patients got cognitive impairment. Do they have a big meningioma? Do they have normal pressure hydrocephalus? Is there something else going on? And then if you were a little bit more sophisticated and tuned in, you might be doing quantitative assessment of brain volume changes, these AI-driven packages, which are really very good at doing brain segmentation. Here you can see that, you can see some of the individual structures that these softwares can actually segment for you, and they leverage artificial intelligence and deep learning to improve the quality of that segmentation over time. But essentially, you compare the brain volumetrics, the critical structures that are involved in, say, Alzheimer's disease or in other conditions. Dr. Johnson talked about using the same quantitative AI-driven tools for following up multiple sclerosis. In this case, you look for brain volumetrics that may point to a certain degenerative brain condition that could be helpful in terms of identifying which dementias there are. In this case, we're looking for the hallmarks of Alzheimer's disease, which would be appropriate for this therapy. There are certain volume loss phenotypes that you can sort of hand wave your way into saying, this is what this is. In Alzheimer's disease, you can see we typically get hippocampal and temporal atrophy. The frontal lobe is typically spared and the parietal lobe can be involved. Not a lot of white matter lesions. In frontotemporal dementia, typically you'd expect there may be some hippocampal involvement, but the greatest involvement is going to be frontal and temporal, with no parietal involvement and typically no white matter lesions. Diffusion of Lewy bodies, the dementia of Lewy bodies is, doesn't have any classic anatomical patterns. You can see a number of different things. And the vascular dementia, as you might expect, lots and lots of white matter lesions, perhaps with some temporal lobe or hippocampal involvement. Now, this slide comes to me as a courtesy of the folks from Icometrics, and this is the way they like to depict this because I think it's very, very communicative. In the middle of this, this target is the highest percentile of volume. So in other words, normal, 99th percentile. But when you start to get out to the edges, you start to get down to the point where maybe only 1% of the normal population has a brain volume that small, which tends to point to then you start talking about outliers against an age-matched population, and you can use this target to sort of point to certain things from a distance. I mean, from the back of the room, I can see that that's a normal case, right? But if I start to have low volumes in the hippocampus and the parietal cortex and the temporal cortex, to me that's a classic pictorial graphic manifestation that this is an Alzheimer's disease case, whereas in this case, you'll notice the hippocampal volumes are close to the middle. That's still pretty normal. The parietal ones are also, pretty much right in the middle of an age-matched population, but you're really down at the lowest percentiles in the frontal and temporal lobe. Now, what these tools can do for you, other than making this diagnosis, is something that goes beyond our ability to appreciate, and that is evaluate interval changes over time. And a lot of folks think that these quantitative tools will be used over time to again track therapy. When you look at the actual protocols that have been promulgated by the American Society of Neuroradiology affiliated multidisciplinary study group with which I'm affiliated, we're always recommending that folks do a 3D T1 as their T1 on these cases, because if indeed a doctor wants to order a volumetric assessment, even in the middle of the therapy, you will be able to do the longitudinal assessment from that data. So it's an easy way to add this. But we really can't see these subtle interval changes, but these tools are very good at saying that there's a trend between the old exam and the new exam pointing towards interval frontal lobe volume loss. Notice in this case, the hippocampus was very low before. That's already burnt out, but we're starting to go from hippocampal, temporal, now to frontal involvement in this case. Here's a very nice case that was loaned to me by Dr. Bash. You can see the patient was originally seen in 2009. You might suspect that this was an Alzheimer's disease. Does look like there's asymmetric temporal lobe volume loss. It was clinically suspected, so the patient had an FDG metabolic PET. And you'll see in this metabolic PET, fused to the CT here, fused to a subsequent MR here, that there's pretty clear, distinct hypometabolism in the temporal lobes. This patient came back in 2016. You can see that the atrophy is clearly progressed, where your first-year residents might be able to say that this is clearly a temporal lobe volume loss Alzheimer's disease case. But in this case, the patient had volumetrics done. And you can see in this case, there's clearly hippocampal and temporal, in this case, even frontal lobe volume loss at this point, pointing to Alzheimer's disease. The patient had a subsequent amyloid PET. Is this positive or negative? Does it mark the white matter or go all the way out to the edge of the brain? This goes all the way out to the edge of the brain. This is a clearly positive case. Now, MRI has an important role in these therapies. You can't get on the therapy, you can't initiate therapy unless you have a recent MRI. And this recent MRI is there to screen for conditions that increase the risk of hemorrhage. As you'll hear in a moment, these amyloid targeting therapies lead to inflammation of the blood vessels, and of course hemorrhage would be a natural accompaniment to inflammation. So we look basically for prior bleeding, how much stroke, if there are any vascular lesions. The longer list looks like this. And obviously this is an example of amyloid angiopathy here with lots of little chronic hemorrhages in the brain, siderosis on the pre-screening exam, which suggested been significant prior bleeds. More than 4 microbleeds would keep you, would exclude you from the therapy. And again, anything that points to the proclivity of hemorrhage would, including lots of old infarctions, softer indication, would essentially lead to exclusion from these new drugs. The primary reason that we are involved in imaging and why we may need to gear up our capacity to do scans is that we are required for longitudinal surveillance for ARIA. ARIA is a cute little acronym which stands for amyloid-related imaging abnormalities. That term may eventually die off because we now know what these are, right? These are not some mystery effect. These are actually pathophysiologic changes that occur from mobilization of the amyloid. Mobilized amyloid in the brain is inflammatory. The amyloid in the brain, the first place it goes, the highest concentration is in the vessel walls, in the perivascular region. If you mobilize that amyloid, you produce local inflammation. That local inflammation will inflame the blood vessels and will lead to the complications known as ARIA. You can see in this particular case, you can recognize some of this brain vasculature. The little red spots on the arteries are actually amyloid plaques on the arteries. And you can see in this little inset here, blown out here, that there's actually an aneurysm that's occurred, and this green is supposed to indicate hemorrhage into the soft tissues. So again, the vascular inflammation leads to leaky blood vessels, which will leak water on the surface of the brain, a sulcal effusion, or water in the substance of the brain edema. It will lead to hemorrhages, which can be microscopic or can be on the surface of the brain. In the brain, microscopic; on the surface of the brain, siderosis. This is a classic example of ARIA-E. This is a flare. The cell size should be dark. You see the white arrow and my little Belinda's wand here pointing to the fact that these cell size are hyperintense compared to the rest of the brain, which is really nicely suppressed on this flare scan. One focus. Here's a patient with more extensive involvement, 3 individual foci. These findings with ARIA, particularly ARIA-E, tend to be transient and resolve relatively quickly. Nearly all by a year. This is a patient seen in November 2021, same patient seen in March 2022, and you can see these ARIA changes are transient. They tend to happen early in the treatment because it is about vessel wall inflammation. So the first place the amyloid is going to get mobilized is in the vessel wall. Once that's done being mobilized and maybe the other stuff's being attended to, you have a less likely to have the vessel inflammation. Here's a patient pre-treatment on the left, post-treatment on the right. Red circle marks a bunch of little black dots, and this is what microhemorrhages look like associated with these amyloid targeting therapies. If you look at a cadaver specimen, this is what it looks like in cadaver. Same little black dot, that we see on imaging. Again, you can also see ARIA-H as siderosis, and you can see on this susceptibility weighted image, the same patient we showed you before, you can see that there is clear hypointensity surrounding multiple contiguous sulci. So here's an interesting case from the literature. Patient was seen baseline screening, no contraindications, normal looking T2, normal looking gradient echo, normal looking flare. At the 4-week surveillance MR, you can see there's a little bit of edema and maybe a little microhemorrhage, okay? These mild changes, and we'll talk about what's mild, moderate, and severe before we're done, don't lead to a cessation of therapy. You continue therapy through this, and this patient stayed on therapy. You generally get these injections every 2 weeks, so several injections later, you can see that there are now 3 microhemorrhages and a larger area of edema, which in this case probably led to a temporary cessation of therapy. Now here's a recent case from our clinical practice. As in clinical practice, things are a little more gray, and this was loaned to me by Rachel Gordon from Los Angeles, and this patient had a PET MR. It was a typical patient, 79 years old, cognitive decline, considering amyloid targeting therapy. This is a brain PET MR. To me, this looks like a normal brain PET. Maybe it was read as equivocal by the team. The patient ended up getting on therapy because the screening MR was normal. Everybody sees this. Really nothing remarkable in the brain MR exam. If you want to look for hemorrhages, where do you look? You look at your susceptibility sensitive sequences, right? In the clinical trials, the susceptibility weighted sequence they used was a standard old-fashioned gradient echo. That's very, very important because all the clinical guidelines are based on evidence of hemorrhage on a standard gradient echo, not the fancier SWI. Will the SWI be more sensitive? Sure it would. Okay, but that's not the way the clinical decisions are made. So that same protocol that's recommended nationwide insists on a basic gradient echo. If you have both, would you do both? I wouldn't, because it doesn't add anything to my ability to treat, and it adds additional complicating information which makes us work harder, which makes the explanation more difficult, and theoretically could fuel some lawyer's concern. The clinical treatment is based on that gradient echo. Getting back to this, normal looking scan, but when you look at this patient's SWI, which was done at baseline, you can see there are two actually microhemorrhages. These are the individual phase images where hemorrhage is bright, and this is the typical SWI where you see the little tiny black dot. This patient also had cognitive imaging, had the quantitative imaging at the initial event, and when you look at the study, it would look pretty remarkable. I believe this is from the Cortex folks, and you'll notice those blues, those are all high volume areas, so these are all normal. This patient has a temporal lobe volume. You can see here that's better than 90% of the normal population, so it looks normal. Except, interestingly enough, the posterior singular region where tau likes to show up is the smallest. There's only 2% of the normal population that has one that small, so it's kind of interesting. Nevertheless, I wasn't involved when these decisions were being made. This patient went on therapy, and this is the patient's baseline exam. After 4 doses, you come back, whether you're symptomatic or, and in this particular case, you do this routinely to look for ARIA. In this particular case, the patient was asymptomatic, and look what we see. We see, a large area of edema within the substance of the brain, classic ARIA-E. So this patient had to have therapy stopped, and we'll talk about what criteria are involved. We'll give you some test cases to go through yourself. And you can see, so baseline, after 4 doses, large area of edema led to temporary cessation of therapy, follow-up examination before therapy could be reinstituted. You can see that the study becomes normal. Interestingly enough, if you go back and look at the areas that were involved, there was a third area of hemorrhage that occurred. This is vessel wall inflammation. In this case, it got edema, it resolved. A little hemorrhage also happened, and that they won't resolve. They'll be there forever. You'll always see them. All right, so this ARIA, amyloid-related imaging abnormality, essentially amyloid mobilization-related vascular inflammation and edema and hemorrhage, has an incidence with donanemab about 37%, with lecanemab, the first drug, the only drug we have right now, only about 21%. But most of the time, these patients are asymptomatic. Okay, only 6% in donanemab trial, only 3% in the lecanemab trial, and these events are generally mild and self-limited. But serious events have occurred. Now, people have died. I think the people have died that have been on anticoagulation while on these drugs, and I think we're a little bit smarter, but I think when we get out into the community, I think you will see more adverse events, you will see higher numbers. But the point I want to make here is that the neurologists who are giving these patients the drug are skittish about this. I don't think they're comfortable with a drug that can do this kind of damage and this kind of impact, and they're nervous. So they will be more anxious to scan patients even outside of the regimented surveillance intervals than they would be in other circumstances because they're worried. Okay, and this is the reason why. Now, at RadNet, this is sort of the workflow we give to our people. Okay, and theoretically it would be used by the neurologist, but I expect that the neurologists know about this. But the other thing you need to know about neurology, about this circumstance, is that when this thing starts to become widespread, there are not nearly enough neurologists involved to treat these patients. Not nearly. So they will start to get out of the neurology population into other populations of doctors as well, and in which case they may need some of the guidance. This just lays out the actual workflow. We've covered some of this. Now, you'll notice at the bottom there's a monitoring interval, and this is the way the monitoring interval falls out. This is from the Leqembi package inserts. In other words, the FDA has essentially said when the companies go out to market, they have to mandate this particular follow-up interval. They want routine monitoring before the 5th, 7th, and 14th biweekly doses. So in other words, a baseline exam, 3 more within 6 months. Most clinical guidelines point to additional scanning at 6-month intervals. Again, the inflammation, the bleeding, the edema tends to occur very early. After that, the risk really starts to drop off, but additional scanning at 6-month intervals. So the typical patient will get at least 5 exams in the first year. Now again, because of the clinical concerns, if you have a headache, something's not quite right, you're going to get another scan. Okay? If you end up with ARIA and you have to stop therapy, until it's resolved, you're going to get another scan. So it is not at all ridiculous to project that these 15 million patients may get 10 exams a year each during this time. I mean, I want you to think about what that might mean in your communities. Just the announcement of a previous drug being available, which ended up not really taking off, led to a 30% boost in brain MR volume in the month after the announcement in New York City. This is before this drug even became available. Okay, so it's a very big deal. And by the way, if you have an ApoE4 allele, which can be determined by genetic testing but isn't required for these particular drugs, you are going to have higher risk, as we talked about earlier, and you're going to get even more intervals. Now, I talked about a protocol. I probably should have put the protocol in this talk. This is the first time I'm presenting this to doctors outside of my organization. But so this slide is not particularly valid for you guys, except to say 2 things. A volumetric T1 is recommended. Doesn't really take any longer than a routine T1. As a matter of fact, instead of doing a sagittal and an axial, some people do, we recommend that you keep the exam shorter by reformatting that 3D T1. So it's a little different from the routine exam. As I mentioned, you need a flare. It's basically a routine brain exam with a shift to a volumetric T1 and insistence on the gradient echo. And my recommendation, even if you have SWI, I wouldn't use it. This is what our ordering templates look like. So it's very important for the doctors who are treating these patients, sending them to us to tell us why they're there. Because it's really hard to make this diagnosis prospectively when you're not tuned into this particular condition. And even if you are tuned in and a highly skilled neuroradiologist, you'll see it's very difficult. But we ask the doctors to tell us why they're there, so we know what we're looking for, and then to stay tuned into the key elements. And if they want to add the volumetric assessment, they can go ahead and add that. All right. So what is our obligation? We are obligated to detect and quantify. Very important. This is a quantification task. Detect and qualify. We need to determine whether these complications, ARIA, are mild, moderate, or severe. If they're moderate or severe, generally we have to hold therapy. If they're mild, we can go forward. If you look closely at ARIA-E, the edema, if it's unifocal or less than 5 centimeters, it's mild. If it's large or multifocal, it's moderate or severe. You have to suspend dosing until those findings resolve. With respect to ARIA-H, again, if you have one area siderosis or less than or equal to 4 microbleeds, you're mild, okay? And you can continue therapy. But if you're moderate or severe, you've got to stop therapy. And if you get into the severe category, you are permanently excluded for further therapy. All right, a couple of cases. How does this play out? Pre-treatment, post-treatment. What do you see? In the red circle, you see an area of edema, relatively small. This patient could probably continue therapy, right? This turns out to be a unifocal, less than 5 centimeters. You can continue therapy, okay? That's the way it plays out. Here's another patient. Baseline, some white matter disease. Post-treatment, now we've got 3 areas. Where does that fit? I want you to think your way through this. Where would it be? Mild, moderate, or severe? In this case, it looks like let's say they're all 5 centimeters, but there's multifocality. In this case, with multifocality, you fall into the moderate, and in this case, you have to suspend therapy. Again, these are typically transient and resolved. Here's a patient who's got a small area of ARIA-E. How would that be? One small, less than 5 centimeter focus, that's mild. This patient also has what looks like 4 microhemorrhages, less than or equal to 4 microhemorrhages, that's mild. What will we do with that? Be in this category. If you're mild, you can continue therapy. Mild E, mild H. Okay? Again, this is exactly what is expected of us in our reports. There are actually suggested templates that actually force you to report these individual items. On the left, pre-treatment. On the right, post-treatment. What do we see? Well, I think even at this magnification, you see at least 1, 2, 3, 4, 5, maybe even 6. So with more than 4, what do you get? You're at least into the moderate category. With the moderate category, what you have to do? You have to suspend therapy until these findings stabilize. Okay? They're not going to go away, right? They will stabilize. All right, so presented like this piece of cake, but it turns out that ARIA is, these findings can be very subtle, and they're certainly somewhat unfamiliar. And when quantification becomes important, it needs to be standardized and consistent. And early publications have suggested that we're really not good at this. 84% of ARIA findings can be missed by people who are actually out there reading. This is a recent publication, by the way, that just came out recently, that looked at the value of AI-based quantitative tools augmenting the interpretive process in these amyloid targeting therapies. They actually selected cases from the clinical trials that led to the drug approval, and the readers were representative of the kind of people that will read these cases, neuroradiologists, even neuroradiologists who are trained in reading for ARIA, as well as, in your clinical practices, you may not have enough neuroradiologists to read these scans. And as you see, they're not going to be a small number of scans. Okay, so it was really representative of normal readers. I think this is just to show some examples from the slide, the performance of the individual tools. You can see in this particular case, there was, these are ones that were concordant. The radiologist read it and the AI read it well. You can see we got some hyperintense sulci here. This is what the radiologist marked out. This is what the AI tool marked out. Really nice concordance in this case. Here's another case. The radiologist marked out, here's the edema. You can see it there. The radiologist marked out the edema. But you notice that, let's just show you, the radiologist marked it out and the AI marked it out. It's interesting that this little area of periventricular white matter that I can't see on the prior was marked by the radiologist but not by the software, but there's really good concordance here. Here's an example of siderosis. You can see it here in the white box. You can see it here. And again, this is what the AI did. This is what the radiologist did. Worked great. All right? Now, here's another case. You can see this tiny area assigned to solitary microfocus. And again, good concordance between the radiologist and the AI. Okay, great. In this particular trial, in unassisted reading, about 30% of the edema and 31% of the hemorrhage were actually missed. More than 53% of mild ARIA-E was just missed. Okay, 40% of ARIA-H missed. And when it comes to the really important stuff, when you've got to stop therapy, 16% of the edema, 14% of the hemorrhage that was moderate or severe were missed. With the AI tool, the sensitivity and specificity improved. Okay, particularly sensitivity, as you can see here, it went up from 87% to from 71% and from 79% to 69%. And it was particularly helpful in improving the detection of mild cases when the imaging findings can be subtle. As you can see for the ARIA-E mild cases, sensitivity went from 70% with the tool to 47% without the tool. All right, let's look at some cases where there was a discordance. You can see here, unfortunately, I messed up the animation, but you can see here, this was not identified by the radiologist, but was identified by the software, and this was not on the pre-treatment exam. Here I've done a better job. Pre-treatment, post-treatment, you can see there are some more lesions. The radiologist did not identify the new lesions, but the software did. Here again, we have, I guess I screwed up that animation for you as well, so let's go to the next one. And here you see a small area of siderosis, marked out here. The radiologist did a reasonable job marking out those areas. So, in this trial, there was a significant boost in the accuracy of interpretation in ARIA-E, as well as ARIA-H, and you can see that here, the impact of AI. And more importantly, when you see these categories for edema and for hemorrhage, no, mild, moderate, or severe, again, when you shift into this category, you have to stop therapy. You notice that there is a substantial change in the number of patients that got into stop therapy when you added the AI. So as in most areas, as in medical imaging, the AI-based tools can help us and improve our abilities to go beyond typical human capabilities. And in this case, where quantification as well as detection is important, I think these tools will become important to us and critical. None of these are FDA approved at this point. I expect that this year you will see offerings from multiple different vendors. So whichever company you work with, it will likely be offered to you by the same company that is offering you quantitative volumetrics. Okay, so they will all have a product. By the way, in terms of quantitative volumetrics, since I have a minute left, anybody ever do these tools, do these studies? If you've done them, you've struggled with reimbursement. And what we used to do is use a workaround code for 3D processing. It was widely done. Inappropriate, but widely done. Nobody ever came out and said we were wrong, but it just wasn't intended for that. The good news is there is now a CPT code for quantitative volumetric assessment. There is a code. It is beginning to be paid in the hospital setting, about $236. This has not translated across to the physician fee schedule for outpatients, where these patients are going to get evaluated, but it is progress. So there is a vendor-agnostic code for this type of assessment that essentially will be a tool that enables AI-based enhancement of our ability to interpret. So we've covered a lot of material. As I mentioned, it is all probably even better laid out in this article because I'm not sitting here in the morning trying to get my wits together. It will cover all the critical concepts. It's still current, even though it was published just maybe 6 months ago. And I encourage you to look at that, and I hope that was interesting and challenging for you and fairly exciting. That article is in Applied Radiology. I believe if you search under my name, you will find it there, although I heard recently that eluded the search, but it won't elude the search forever. So thank you for your attention. I hope that was fun.